Good morning, everyone. I see that some sisters and some brothers are coming in at the back. So let's see. Give them a moment to sit down. Good morning. Good morning. Good morning. Yesterday evening was a very busy evening. And I know that you all went to different things, but about 1,000 of us danced all night. And it was a great evening. It makes such a change to your heart when you see all of us come together and have such a nice time. Really, it was a very nice evening. Even though the room is not totally full, I hope it will become more full in a few minutes. But we have prepared for a very exciting plenary session this morning. It's one that explores the art of the possible, and that is also why we are here, to expand, to try out, to scale up, and to really strengthen our profession in every possible way so that we can serve women, newborns, adolescents, young girls, even stronger. The topic of today is midwifery models of care, improving outcomes and shaping the future. I touched upon this when we opened on Sunday, and actually a colleague of mine at the World Health Organization, she explained it to me very early that I should think of a hairdresser. And I'm going to ask you, how many of you go to the same hairdresser over and over again to have your hair cut? I see a vast majority of hands. And why do we do that? Well, my hairdresser, her name is Lena. She knows who I am. She knows what I want. I trust her. She's very professional. She gives me appointments that suits me when I'm home. And we just know each other. And it's such a feeling of trust that I really appreciate. And I think that's very much resonates to the midwifery models of care that we now will hear so much about. So think a little bit about your hairdressers and how the principle is applicable on midwifery models of care as well. I'm very honored to welcome our keynote speaker, Janhavi Nilekani. She's the founder of the Astrika Midwifery Center in India. Janhavi, please join me on stage.
Hello, everyone, and thank you so much for having me here. I'm very short, so I will adjust this mic. So I'm from Bengaluru, a cosmopolitan city in the south of India. From the more comfortable backgrounds, I had access to the best of Bangalore's hospitals. And when I was pregnant in 2016, I actually was quite shocked to realize that the best of India's hospitals don't offer such good maternity care. I was a development economics student at the time, pursuing a PhD in public policy at Harvard. And like any other development economics student, I was very familiar with the challenges of too little, too late, right? That in India we have high infant mortality rates, high maternal mortality rates, and this was more true, of course, 10 years ago. But I had not, till I was myself pregnant, realized the depth of India's too much too soon challenge. When I, at the time in Bangalore hospitals, the maternity hospitals, from what I heard from my friends or anecdotal data, it was an 80%-ish C-section rate. Today, now we have a lot clearer data. It may be more like 70, 75, but that is more than bad enough. In Karnataka, the state I live in, the private sector C-section rate at a state level is now 64%. Individual hospitals in Bangalore, like the ones I was visiting, were more. At the time, as I mentioned, I was a PhD student at Harvard, so I was going back and forth between Cambridge, Massachusetts, and Bangalore, where I was doing field research on a randomized controlled trial in the south of Karnataka in 34 taluks. And frankly, I was aghast at the difference in the standard of care, because I was going back and forth in the first trimester, second trimester, and the third trimester, and it was almost whiplash, the difference between what I was able to get in America and what was available to me in Bangalore. And again, these are fancy hospitals. They will do perfectly safe C-sections. It's not bad quality in that sense. It's bad quality in terms of decision-making, of a lack of following protocols, of a lack of staying up to date. And I think a couple of things really bothered me. One was, I was still able, through speaking to people, to find obstetricians who were willing to try for a normal delivery. I still found people who said, okay, you're young, you're healthy, we'll try for a normal. I could not find a single obstetrician in Bangalore who agreed to not do a routine episiotomy. I argued a lot. I brought out, randomized controlled trials, systemic reviews, WHO guidelines, ACOG, RCOG, whatever. And what my obstetrician said, and it has stayed with me for 10 years, and it was very sincere. It was, but Janvi, all that research was done on white women, and you're Indian. And that is actually the mentality in India, right? That it doesn't matter what global research says about episiotomies. Indian women tear easily. In India, this is what is needed. And, it was so set. So the other thing which really, really bothered me was the lack of informed consent. And that, again, was a sense of whiplash. Some of you, you know how IRBs are. And Harvard's IRB was driving me batty with the degree of informed consent they wanted for me to talk to bus drivers. And yet, at the same time, the lack of informed consent I was getting in my maternity care was something I could not handle. So I actually tried for a long time, because I live in Bengaluru. I had the option of Harvard, but for other reasons, I didn't want to have my baby in America. And it was a big challenge to leave the city to find, medical tourism at the end of the day, even me, with all my privilege, did not have family support for it, because in India, it's so normalized that, women should tolerate poor quality childbirth. The idea that a positive childbirth is something we should strive for, even today barely registers, and 10 years ago was fairly unheard of. But finally, my cousin sister gave birth at the same hospital I was going to. And, I knew about the episiotomy, but till my nephew was born, I actually did not know. They still don't completely allow a companion, and they still do pubic shaving and enemas. Because I was living in the US, I was reading Emily Oster, even to the extent of knowing bad things about maternity care, it was still the level of episiotomies. Not that, oh my God, you all are still doing enemas. And that is when I abandoned Bangalore. I traveled to Hyderabad, to Sanctum, one of the handful of midwifery centers in India. Vijaya Krishnan, my midwife, is not here this time, but has presented at ICM in the past. And I had a beautiful birth experience. It was till now, one of the best memories of my life. For me, what I wanted was an evidence-based birth. More than, I'm not someone who really was very particular about it being a normal delivery or a natural childbirth. For me, I needed it to be evidence-based. I was very comfortable with interventions, provided they were required. What I was not comfortable with was, the Indian tendency to do interventions without paying attention to protocols, guidelines, or necessity. So, I think what midwives offer is that informed consent and respectful maternity care is core to the DNA of midwifery. It's not something that has to be trained later like what we are doing with obstetricians and nurses in India. Midwives are trained from the get-go in the culture of women-centric care. And that's how it became that though I was not seeking midwifery, I was seeking evidence-based care and informed consent. I found it only with midwives. So, and Vijaya won't mind me saying this, the only points where she and I differed were, I was like, no, I want active management of third stage. I am a data person. I don't back this. And that I refuse to wait past what at the time was 42 weeks, I think, for. But the thing is, with the midwife, with her default protocols and what evidence-based things I wanted, how I was reading the evidence, any differences were very fine and in gray areas where both choices were reasonable. And especially because, Vijaya we could have that conversation that, yes, I know that you typically prefer physiological third stage management. I've looked at the research, and for me, I want EMTSL, and she's like, sure. And that entire conversation was completely not possible with the obstetricians in Bangalore that I was otherwise speaking to. The thing for me, which even now, after all these years, is something which I gloat over almost. Because I had wandered around Bangalore and not found a single doctor who was willing to not do an episiotomy. And I really fought with them. I said, you say Indian women tear, but you never do anything to prevent tearing. You assume they will tear and do an episiotomy instead. And maybe you should try, protective measures for perineal trauma. But I never got anywhere with all that. But at Sanctum, I myself literally researched and did every measure to protect perineal trauma, and so did she, and between the two of us. So for me, the fact that I managed to have an intact perineum as a first-time Indian mother, which doctors thought was impossible, still remains one of the things I'm just so happy it worked out. So when I went home, right, from Hyderabad, by the way, I went to Hyderabad for Sanctum and Vijaya. I knew nobody and stayed in a service department and fought with my whole family about it, because I always say that my childbirth, my experience was the childbirth version of an elopement. I fought with everybody to abandon Bangalore, because the idea that women's autonomy and women's morbidity should be centered as a priority in childbirth was something that even for my extremely progressive family was outside what they could adjust to. Now my parents think I was right, but at the time they thought it was crazy to travel for a childbirth. So once I came home, something I realized was that many of my friends and family had never actually heard a positive birth experience. Every Indian friend I had actually had something which was ranging from traumatic to like, yeah, it's just something you have to get through to have a child. And that itself was an eye-opener, that we had, positive birth experiences was so rare in India that the idea itself came as a shock to many people. So by the time I had finished this entire experience, I had really become passionate about maternal and newborn health, and also midwifery in particular. So when I graduated from Harvard, I founded Astika Foundation. Many of us are here. We started in 2019, and we do a range of work. The way we kind of diagnose India's maternity care challenges is that broadly they fit into 3 buckets: too little, too late, too much, too soon, and disrespect and abuse in labor rooms still being extremely common. So we work on all of those 3 challenges. we have, I would say we have 3 large buckets of programs. One is capacity building of the existing healthcare cadres. So we work with everybody from doctors to nurses to security and housekeeping on things like respectful maternity care, best practices in birthing, evidence-based medicine, and so forth. And we've been very successful with that. We also do other public health training. So we have worked with 300 to 400,000 nurses and others through the healthcare system in India in partnership with state governments. A lot of that was not on maternity care, so those were online digital programs where we do all types of public health. Our in-person programs, training programs, are very much focused on maternity care, with a key focus on scaling respectful maternity care and basic principles of evidence-based medicine. So all those are called Sphere, and that's one of our wings. We also do advocacy work. We really think the idea that Indian culture needs to normalize the idea that a positive birth experience is something to aspire to. Something I say, though I picked it up from Neil Shah, many of you may know him, and Ariadne Labs and Team Birth, is that survival of the mother and child has to be the floor of our expectations, not the ceiling. We can't say, okay, we've hit we cannot stop at saying, okay, we hit the SDG goals, MMR is under 70, IMR is in range, and therefore tick box and let's move on to tuberculosis, right? Okay, TB is important. I'm not dissing NCDs either, but we cannot be satisfied by saying that India's women and children have survived up to the SDG goals. Striving for an actual positive birth experience, high quality care, informed consent, and respectful care remains really something we need to aspire to, and that's where we put a lot of our advocacy efforts. And then there's all our work with midwives. That's another huge program of ours. So in 2018, the government of India finally introduced the idea of a specialized midwifery cadre. So in India, GNMs, ANMs, there are many versions of nurse midwives who are primarily nurses with a bit of midwifery training. But in 2018, the idea of a professional midwife, a nurse practitioner in midwifery, trained to ICM competencies was introduced. So a handful of nonprofits are engaged in that effort. I think all of us are here in this room. And the way India had envisioned it was that there would be a national midwifery training institutes where international faculty would train Indian faculty. And then the Indian faculty would go on to train midwives at state midwifery training institutes, and that the midwives would care for low-risk births in midwife-led care units, MLCUs. That it's been now several years since that program was launched, and I will be honest, and other Indians will agree, it's been middling, right? It has been a real struggle in India to introduce midwives. I would say that after all these years, and this is a country with 23 million births a year, we have maybe 1,000 midwives, not even, 700 to 900 midwives trained to ICM standards in the country. And all the people who train them are around here in the first row of this chair. There are maybe 30 to 40 public sector hospitals which have a midwifery team, like an ICM standard midwifery team. And I can think of somewhere between 4 to 7 private hospitals, depending on how you define, depending on who counts in terms of how obstetrician-led or midwifery-led they are. So that is the backdrop. We still feel it is worth pursuing midwives, even if it's going to be a small and slow program, because midwifery sets the bar. Right? Midwifery acts as a fulcrum of change. When people see the kind of care midwives and midwifery-led units give in India, it changes the benchmark for the country, and that does create change, even if we never have more than 5,000 midwives in India. So we do 2 things within midwifery. First, we are the Karnataka partner. Astrika Foundation focuses on launching midwifery in Karnataka, and it's been one of the states where midwifery is sort of surviving, or we're establishing itself slowly. We've done batches of midwifery faculty. We've trained about 100 midwives. We partner with the government hospitals 12 government hospitals in different districts. It's an ongoing effort. We think it will take at least 5 to 10 more years for midwifery to be established, even just in this one state. But we are committed for the long haul. Separately, we have a private hospital, Astrika Midwifery Center, where we practice interdisciplinary care. There, we have a model where midwives and obstetricians work together. So unlike in the government, where midwives are prioritized for low-risk women, at Astrika Midwifery Center, our private hospital, we very consciously have an obstetrician and a midwife involved in every birth, regardless of whether it's low risk or high risk. And that is twofold. One is high-risk women should still have the care of a midwife. But the other is also the honest reality that in India, midwives do not have any autonomous scope of practice, so you do have to have an obstetrician involved. And also that midwives are so rare and unusual in India that the market is not okay with not having an obstetrician. And which is all right, because there have to be many midwifery models in the world. In a country, unlike, say, Sweden, which has this continuous centuries, decade of midwifery practice, in a country where midwives, professional ICM standard midwives, have been introduced less than a decade ago, we cannot expect people to be okay with that. It has to be in India's private sector market, an interdisciplinary model, and that is our bet. At least that's our bet to scale. There are a handful of very midwifery-led centers in India, but those depend on individual outstanding midwives, not on a very scalable system. The other reason it was important for us to have a private sector midwifery is I truly believe that it'll be a shame if in India midwifery becomes another government program for the poor. Midwifery is important for all women, not just for the poor. It is establishing midwifery as aspirational is part of why we have a private birth center. So I don't have too much longer. I think I will come to, in a sense, we've had to experiment with different midwifery models of care given the state of where India is. So the MLCUs, the midwife-led care units in the government hospitals, to be truthful, have not easily worked out. They hinge on the obstetricians in that hospital defining a woman as low risk enough to be sent to a midwife. And the obstetrician standard, out of 50 births a day in Vani Vilas, we struggled to get one woman a day considered low risk enough to come to the MLCU. At this point, this is more about defining everybody as high risk than that 1 out of 50 are the only low enough risk women in the labor wards. So I think we have adapted. Whichever of these 12 hospitals we are able to have actual MLCUs with midwife-led care for low-risk women, we are doing that. In most hospitals, we are recognizing the reality and deploying midwifery teams in obstetric-led units. And that has its own benefits. First and foremost, it is much more effective at advocacy. When we had a handful of low-risk mothers being put over there with the midwives, yes, those mothers got excellent care, but we did not change the system. Whereas midwives working day in and day out with obstetricians in their rooms is having systemic change. There are so many doctors who have never seen a woman give birth without an episiotomy till they watch our midwives. And because we work in the biggest of government hospitals, which are medical colleges, we really hope those doctors will take their learnings to them wherever they go. So just to wrap up, I think, my own story, I'm deeply grateful for midwifery as a profession, and Vijaya in particular. For Astrika, we do a lot of work in general maternal and newborn health, including with other healthcare cadres. We recognize midwifery is only one solution in India, but it remains what we see as one of the most important arrows in the quiver, that midwives set the benchmark, and that affects the whole market. And that is also why we believe it's important both for government hospitals and for private centers. So it's been for these few years, I think since Fernandez started midwifery was in 2011, Priyanka and Vijaya have had midwifery centers for maybe 15 odd years. For less than 2 decades, I think midwives are slowly becoming an established concept in India. It is in pockets, it is not everywhere, but it is there, and that's something we all strive to continue to work towards. Thank you.
Good morning, everyone. My name is Ulrika Renström-Loy. I'm a technical officer with WHO in Geneva, and my portfolio is midwifery models of care. And I'm super excited to be here today at this ICM Congress to speak about midwifery models of care. And I have with me a fabulous panel of 4 midwifery leaders, and I will give over to them to introduce themselves.
Thank you. Hello, everyone. It's truly an honor to be here and to be a part of this conversation here today. My name is Emma Swift, and I am a midwife and researcher from Iceland. In my role as professor at the University of Iceland, my research focuses on models of maternity care, obstetric interventions, and childbirth experience. Alongside my university position, I'm also the co-founder and owner of the Reykjavik Birth Center, which is a freestanding birth center in Reykjavik, Iceland.
Please, Doreen.
Thank you. It is a great honor to sit here in front of you. My name is Doreen Kainyu Kaura. I am a Kenyan who works in South Africa, Cape Town. I work in the University of the Western Cape and the University of Stellenbosch, and my role is being a professor in midwifery. We also work in the clinical area where we follow up students. Thank you.
Hello. Good morning, everyone. I'm glad to be here with all of these leaders. Ru'ad Tawili. I'm a consultant midwife and assistant professor of midwifery from Saudi Arabia. I have worked as a clinician, leader, advocate, and educator for the midwifery profession in Saudi Arabia. I am passionate about advancing midwifery continuity of care models in strengthening midwifery education and ensuring that women and family receive respectful, evidence-based, and women-centered care. And I'm running a private midwifery clinic in a private hospital. Thank you.
Yat Nicole Arthur Nishan, Glass Chi Nishlant, Do Tochi Ni Bushes Chi Niskai, so Desha Che, Nanis Desha Desha Nele. My name is Nicole Arthur. I am a Dene nurse midwife from the Navajo Nation. I'm an indigenous midwife. I am the founder of Changing Women Initiative, which is a Native women's-led health collective providing integrative midwifery care model in the US, in New Mexico, to the tribes in the Southwest. I'm also the founder of Transcending Strategies. The work that I do around Indigenous maternal health is advancing the rights of Indigenous people, as well as health policy strategy and community engagement to integrate and to create integrated models of care for Indigenous communities. It's very lovely to be here with you all today.
Thank you so much. Thank you. It's really a pleasure to have you here, so very welcome. And today we heard the title of this session is Midwifery Models of Care, Improving Outcomes and Shaping the Future. And I think the title really captures both the opportunities and challenges before us. And that is really what we will be discussing today. around the world, we have made improvements. We have made progress for women and newborns to improve their health outcomes. But as in India, we have heard also that far too women and newborns and families continue to experience really preventable illness, preventable morbidities, and preventable mortalities during pregnancy and childbirth. And like my colleague from India said, it's not just about surviving, it's about thriving. It's about having positive experiences, positive pregnancy experiences and childbirth. So the question before us is not only whether women and families can access care, it's also what kind of care they receive, how the care is organized, and how it's experienced, and whether our health systems are truly designed around the woman and the newborn, or is it more designed to be comfortable for the healthcare providers? So this is really where the midwifery models of care come in. So at WHO, we see midwifery models of care as an important opportunity to rethink how we organize the care to be around the woman, the newborn, and the family. So let's get started and jump in to hear from our dear panelists. We have some questions for you, and let's start with a round of open questions for you. So, Emily, Emma, you are from Iceland, and you explained that you don't have you didn't have birth centers when you started, and you have now set up a team, and you have established a birth center. Could you explain a little bit to the audience what this birth center, how it looks like, and the story behind? What was the challenges that you tried to resolve, and how did you come up with this idea to set up a birth center in Iceland?
Thank you. That's a good question. Before I tell our story, I want to acknowledge that it comes from a certain context, which is very, very different from what Janhavi just was explaining about her background. Iceland is a high-resource setting. It's a welfare state with a small population. We are an island up in the north of Europe. We have a strong, well-established midwifery workforce and a long tradition of midwifery. And midwives take care of all aspects of maternity care. They are in antenatal care, both in high and low-risk settings. We have a midwife for every woman at every birth, and the golden standard is one-to-one midwifery during birth. And in general, both within the public and as well with other healthcare professionals, midwives, they have respect and trust. But at the same time, even though we have all of these wonderful outcomes in terms of a low cesarean section rate, which last year was only 14%, but really, yeah. And excellent maternal and neonatal outcomes in terms of the typical outcomes that we are looking for, right? Yeah. We still don't have any continuity of care. We are still seeing the increase in medicalization, increase in induction, CTG, the closing of alongside units, and the closing of rural midwifery units. So that is our context. So the birth center was really a response to that challenge. And when we thought about building a birth center, it wasn't about changing where women give birth. It's about changing how they are taken care of and how they experience their birth. And so 10 years ago was an important change in Iceland when a birth center was opened for the first time in a long time. And this was a group of home birth midwives, and they were very smart about it because they used the guidelines that were already in place in Iceland and worked within the system and started very small. I think that was the key. And so because there were already guidelines for home birth, they said, but here we have women in rural Iceland that would also like to give birth at home, but they can't because there are no home birth midwives in the rural setting. So we are going to open this place in the capital city where women from rural Iceland can come to the city and have a home birth. So they're having a home birth, but just in this one building. They didn't call it a birth center, and they didn't make a great big fuss about it. It was just working within the system to create this option.
Smart.
Yes. And of course, what happened is they were providing continuity of care and excellent midwifery care. So women in the capital also wanted to give birth there, not just women in the rural areas that wanted a home birth. So it changed quite quickly and opened up this option to women who had never considered home birth, had never considered doing anything different than the hospital birth. They were now considering a birth center. And 4 years ago, when we saw that there was really a need for more options for women because it was so popular, we decided to open another birth center.
Fantastic.
And here we saw a really important shift, because when you have one midwife providing home birth or you have one birth center, it is still a little bit outside of the norm to choose that option. But now you have suddenly 2 birth centers, and it doesn't seem so much out of the norm. And we see this in all implementation science, right? When there's more people doing the same thing, it becomes more normalized and less of a radical decision. So it changed a little bit from, have you heard about the birth center? Is this something I should consider, to which one of the 2 are you considering? And we had a real change in the perception among the public. And in these 10 years, what I've seen is, in the beginning, of course, we had a lot of questions about safety and a lot of questions about transfer. And the questions about transfer were a little bit like, if I have to transfer from a birth center, it's a failure. It's a failed birth center birth. But now, we don't hear these questions anymore because people understand that a transfer is actually a sign of a well-integrated system. It means that we are, we are providing the right level of care with the right providers at the right time and at the right place.
Thank you, Emma. That is fantastic.
And now, within these 10 years, it's really interesting how much can change. And when I reflect on this, I think about how change can feel really slow sometimes. And I'm sure that for the midwives that have been advocating for continuity of care in Iceland for decades, this change seems quite slow. But now, when I see young parents come to our birth center, and they actually are surprised that it hasn't been like this all the time. They say, what? This is a new birth center? It started 4 years ago? What did people do before?
Yeah.
And so then all of a sudden change has started to feel quite fast. So that's really interesting. So lessons, 2 lessons that I feel like we've learned from opening the birth center. I think it's The first is the importance of evidence. And when we opened the birth center 4 years ago, we made a really conscious choice to collect lots of data and to work with researchers at the university and to create databases, because we know that if we want to continue and we want to grow and be sustainable, we have to be able to show that it's working. And so from the first birth, we have been collecting data not only on the typical outcomes of postpartum hemorrhage or tearing, but also on birth experience and continuity of care and access to care. And we've seen that this has really increased the trust in the birth center among the public, that we are able to, when people come to us, they can ask us what's the transfer rate, and I can tell them the latest data, you know, or what is the most common reason for transfer. I can tell them that. But it has also created trust in the government and in policymakers, where we are seeing that they are reaching out to us to want to see our numbers. So this has become a really important part of what we do at the birth center. We almost consider ourselves a research center as well.
Yeah.
Maybe the other lesson is that starting slow and working within what is already in place. We follow our national guidelines to a T. We are not trying to sort of go outside of the norm too much, but sort of more working within the system. And I think this has been important to us, because often when we want to change something in this world or open a birth center, it's really about the desire to do things differently, and so often we go all the way out to try to change a lot at the same time. But really, innovation doesn't always have to require working outside of the system. It can also mean that we are working to move the system forward together.
Fantastic. Thank you so much, Emma, for sharing these. Thank you so much, Emma, for sharing these experiences and lessons learned. You mentioned about policies. You mentioned about how you navigated around the policies a little bit. You didn't break them, but you used them in a smart way. You also took step by step. You didn't take water over your head. You didn't start too big. You took small, small steps, strategically moved more and more. And you mentioned trust. I think trust is one of the biggest achievements that you have to be successful. Trust with the women, trust with the partners, the families, the communities, but also with the policymakers, the decision makers, and the government. So we have to show the evidence. You mentioned that you're collecting data. We have to be able to show that we can meet the women's needs, and we can give the even better healthcare compared to other models. Excellent. Congratulations. Thank you. Doreen, my dear friend, now it's over to you. So you are based in South Africa. Could you please tell us about your midwifery models of care, how you are working? Because I know it looks different from the one we heard from Iceland. So over to you, Doreen.
Thank you, and thank you for this opportunity. When we speak about continuity of care in midwifery, we often imagine pregnancy, birth, and postpartum period. But today, I want to challenge us to think differently. What if continuity of care begins before pregnancy? What if it starts with a 10-year-old trying to understand changes in her body, a young person afraid to ask questions, unsure to trust, wondering whether the health system will protect her or judge her? Before we are truly serious about improving maternal and child health, we must begin much earlier. If I speak to midwifery obstetric units in South Africa, they actually began in the 80s. And this is when the government wanted to improve access in the primary care levels. We refer to them as midwifery obstetric units or midwifery-led obstetric units, and they're within community-based centers, which are accessible to women. Within 5 kilometers, a woman can walk and get to a midwife. This forms the cornerstone of maternal and child health in South Africa, because every public health facility offering maternal and child health first begins with the midwifery obstetric units. So what do these services offer? They have antenatal care, where it's pregnancy, birth, and postpartum. We also have labor care for low-risk pregnancies. We have postnatal care for mothers, sexual reproductive services, breastfeeding support, early identification and referral of complications. The model for MOU is a low-risk birth, which is within the community where midwives are autonomous and make decisions regarding the care of the woman. It is a 24-hour service for labor and birth, 8-hour service for antenatal care and postnatal care, but women can come anytime into the services and they get the service that they require. So when it comes to complicated services, we have moderate risk and high risk, where high risk are seen in tertiary hospitals, moderate risk are seen in district hospitals, and we also have specialist maternity care hospitals. An example is one within the Western Cape. We have 9 provinces in South Africa. The Western Cape has a specialist hospital specifically for maternity health services. So why do MOUs matter? They bring the services closer to the communities, and they serve the communities with the communities. So we have even community health volunteers that actually support the women. They promote normal physiological birth. We have up to 100 to 150 births in the MOUs that are low-risk births. That is why we have low cesarean section rates in tertiary level hospitals. Just for me to go back, we also have the private sector, which is a different ballgame. There, the women go straight to the obstetrician, and the midwives do not perform the midwifery function within the public sector. However, we also have private midwives who offer births to women back at home. So South Africa midwifery obstetric units are more than just birth facilities. They are community hubs where continuity of care begins. They are trusted relationships with midwives because the midwives live in the community, and they also provide services within the community. The Western Cape, I'll give an example of the Western Cape, where level 1 primary care, which is one of the provinces, we have weekly mobile units that go to women in regions that do not have the midwifery obstetric units to reach the women. And then from the weekly visits, then they can refer them to the midwifery obstetric unit, which is 24 hours. But we also have basic antenatal care services, which are also closer than the midwifery obstetric units, because in one province we have 14 midwifery obstetric units, which are public and free services. And then we also have another 18 basic antenatal care services. These services offer even antenatal services up to 30 weeks, and then from 30 weeks, the woman will go now to the 24-hour clinic where she's given the other services, including birth and postpartum. When we speak about district hospitals, then we have the levels of care that have several other functions, including specialist functions. So in the Western Cape, continuity of care is enabled through a well-established referral system where women typically enter the community clinics and midwifery obstetric units. When I speak about sexual reproductive services, what do we mean by that? The adolescents come to the community midwifery services, but they have their separate services which are integrated. This way, it creates a trusted service for the adolescents. We also have school services that the midwives offer. So the midwives come from the midwifery obstetric units and also offer school services, but we also have another cadre of clinical practice nurses who are also midwives that go to the schools and offer these services. So it is a very integrated service, and we see that as a circular kind of system, not just pregnancy, birth, and postpartum. Thank you very much.
Thank you so much, Doreen. Thank you for sharing this very interesting model where you have included the broader SRH agenda. You have included family planning. You have included even comprehensive sexuality education at schools. Very, very interesting. Thank you so much for sharing. Roa, so you are a midwife leader and a strong advocate for caseload midwifery. So we would like to hear from you about your experience developing and also implementing caseload midwifery in Saudi Arabia. So what took you to introduce this model in your context? What was the problems you aimed to achieve? And how does your model look like?
Thank you for this important question. My experience is not with caseload midwifery as much as continuity of care, because I am the only midwife in that hospital to follow women during pregnancy, childbirth, and postpartum. So I would refer to it as a continuity of care model. So my experience with this model, when I recognize a gap in the system and between what women and family needed and what the system is providing. And also, specifically with the private sector, women are not able to reach midwife. It's always an obstetric-led care. And also, there was too many intervention that is forced to the women without consent, without explaining. They just have this intervention. So many women were receiving good clinical care, but they were seeing different healthcare providers through pregnancy, birth, and postnatal period, and that care was fragmented. And many women lack continuity, emotional support, and trusted relationship with their care provider. So they might see a lot of different obstetricians because they are not convinced that these intervention are needed for them. I wanted to open a midwifery clinic because I believe women and families deserve a different experience of maternity care. I wanted to provide family-centered care and support to women to have a physiological birth with fewer unnecessary intervention while being cared by a known midwife throughout their journey. In many ways, I wasn't opening a clinic. I wasn't simply opening a clinic. I was introducing a different philosophy of care, one that placed relationships, continuity, family involvement, and a normal life or normal birth at the center of maternity services. That is why I established one of the first midwifery clinics in private sector in Riyadh. However, this would not have been possible without the support of two obstetricians that believed in the midwifery model of care and Their help was instrumental in helping establish the clinic and integrate this model within a hospital setting. I was fortunate to have their support because they valued the continuity of care model as well. I have now been providing this service since 2021, following women during pregnancy, throughout their, supporting them during childbirth, and continuing their care after birth or postnatal. This continuity allows women to build trust with their midwife and feel supported during one of the most important experiences in their lives. I also provide pre-pregnancy care, sexual reproductive health care, and family planning. So introducing this model wasn't easy. It required building trust with hospital leadership, collaborating closely with supportive obstetricians, and multidisciplinary teams like nurses, pediatricians, everyone in the hospital, and educating women and family about the role of the midwife and the value of continuity of care. It also required persistence because introducing a new model of care means changing mindset as well as systems. At the same time, I recognize that sustainable change requires supportive policies and standards. I was honored to participate and contribute to the development of the Saudi midwifery clinic standards, Saudi birth center standards, and the Saudi home birth standard through the Ministry of Health. Unfortunately, we still we haven't implemented birth center and home birth, but I believe that we have to start small and aim big. So we slowly going there, I believe, because this is part of the Vision 2030 of the Saudi Ministry of Health. So although challenges remain, positive changes happening. More midwifery clinics are now opening within the Ministry of Health, primary healthcare centers across different cities in Saudi Arabia. This demonstrates growing recognition of the value of continuity of care and the important contribution of midwives to maternal and newborn health. This transformation is also being supported by major development in midwifery education. Bachelor of Midwifery programs are available in 10 universities now across Saudi Arabia. We have 7 government hospitals and 3 private universities. 7 government universities and 3 private universities offer this program to help prepare future midwives and future workforce needed to expand midwifery-led models of care. Because I am the only midwife in private sector. Maybe having a PhD has facilitated this because, in private sector, to open a clinic, you have to be a consultant midwife with a PhD to be able. But now there is more acceptable of the midwife role in Saudi Arabia. So there might be a shift that a master degree can open a midwifery clinic, and maybe later we can trust the bachelor degree to have the midwifery clinic. So the benefit of women and family have been remarkable. Women often tell us that they feel calmer, more confident, and more respected when they are cared by a known midwife who understand their needs, value, and preference. Families also become more involved and supported through the experience. As as an educator and practicing midwife, I believe these roles strengthen each other, and combining academia and clinical practice is not always easy, but it keeps me grounded. So for me, continuity of care is more than a model of care. It's a philosophy that places women, family, relationships, trust at the center of maternity services. And when women know their midwife and midwives know their women they care for, everyone benefits. Thank you.
Thank you so much, Rowan. And you can hear we are saying similar things and we hadn't prepared. We are talking about trust. We are talking about relationship. We are talking about keeping the woman and the newborn in the center. And we are talking about seeing them and providing that care that are personalized and person-centered care. Thank you, Rowan. Nicole, so you are a midwifery or midwife leader as well, and you are a CEO, and midwifery models of care have been shown to improve outcomes for indigenous communities, and still we don't have consistently in implementing it. So could you tell us and share your experience about how the midwives are engaging in policymaking has helped the implementation of these models of care in the indigenous communities in the US, and how it has affected these communities. So thank you.
Thank you. I want you to know this issue is a really important one to me, and I hope you're listening. From across the world, Indigenous midwives came to the ICM Congress to learn that not only had the ICM statement in support of Indigenous midwifery been rescinded, but that the term Indigenous midwifery was not permitted in any of the presentations in Congress. This systemic erasure of Indigenous midwives, babies, and birthing people is a continuation of the colonial project that has led to the genocide of Indigenous people around the globe. From the Turtle Island to Aotearoa, from Gaza to Sami, Indigenous midwifery is the foundation of midwifery practice anywhere and everywhere. It is the collective heritage of our craft. In their relentless attempt to patent the term midwife, ICM standards have criminalized our traditional practitioners and disparaged our ancestral medicines, even as colonial midwives appropriated our ancestral practices and technologies. ICM does not, has never, will never own the term midwife. Midwifery belongs first and foremost to the communities we serve. We call on all of our allies here and around the world to hold ICM accountable, to assert their responsibility to repair the colonial legacies imposed on Indigenous peoples, and to stand up in the defense of midwifery that is inclusive to all. Because if you want 1 million more midwives, you must start with Indigenous communities. You must start with us. Thank you.
Thank you so much. Thank you, and we all agree that families, women, newborn and families from indigenous communities, they deserve to have the same outcomes and experience to those who have the absolute the best. Thank you. Okay. Thank you to all the panelists. Thank you so much for your insightful and very thoughtful, provoking discussions. I wonder, today's conversations has reinforced our messages that becoming increasingly clear globally. That midwifery models of care is not simply an alternative way of organizing services. It's really an evidence-informed strategy for improving maternal and newborn health and advancing quality of care and strengthening health system and meeting the women's need and providing the respectful and person-centered care that women deserve. So we have heard examples from very different settings, but very common messages about trust and relationship and meeting women's need. But we also heard that successful implementation of midwifery models of care requires more than a clinical evidence. It requires policies, regulation, sustainable financing, and strong education system, and supportive leadership from midwife leaders, but also leadership within the OBGYN communities, within the governments, and of course, very supportive engagement from women and families, because we need to meet their trust, and they need to see this as a norm, like we heard, that they become familiar with midwifery models of care and what we can provide them. Secondly, while these models, they look completely different in different countries, but still we have some guiding principles that remain the same, that you have heard across the messages from our different panelists. You have heard about continuity, you have heard about trust and relationship. So this is really exciting to hear. So I think we have a few more questions here for you. So I would like you to reflect now, Emma, on how did you involve communities in co-developing and adapting midwifery models of care? How did you engage with the women, the families, and the partners? And how did you touch a little bit on it, how you reached their trust, but could you give us a few more examples? Thank you.
Yes, I think when I think about leadership, you know, one of the things that were so interesting when we decided to open a birth center is that you open it with a vision and with your clinical expertise as a midwife, but what it takes to open a birth center is so much more, right? We had to learn a lot of different skills to, you know, just from creating a website and hiring midwives and engaging. Is there something? No. Engaging in the government and in the health ministries. You know, we had to learn a lot of new tasks as clinical midwives. And I've been thinking about the sort of leadership roles for midwives and for younger midwives. And when we were talking about this, none of this we learned in our midwifery school, right? No. So maybe this is something that we also need to think about, is that these are skills that midwives need to have. And in Iceland, for the past decades, I think it has been really important that we have midwives also in different roles, not only working as clinical midwives, but we have 2 midwives now that are working in the health ministry. We have a midwife that works within the Directorate of Health. And just to have these connections has been really important, and has been important for us to be able to connect to a midwife on these levels.
Yeah, good point. Thank you. Thank you for sharing. Doreen, what about you in South Africa? Do you work anything with civil societies? Do you work with women groups? How have you gained the community's trust, the women's trust?
Thank you. I think that's very relevant to South Africa. And I would agree with Emma when we say leadership is very important, because that's where we begin engaging with communities. As midwives who are in the community within South Africa, you have to work with the communities in order to understand what women need. And what is important, I'll give an example of one of the communities I was working with in the Eastern Cape, which is another province in South Africa, where reducing prevention of maternal to child transmission was essential. And there was up to 45% of transmission in this same region. So collaborating with the communities included involving the traditional birth attendants, involving the community workers, and that was part of what the midwives were working with. And I'm telling you, within 5 years, we had reduced from 45% to 0.45. And that was an achievement when it comes to, thank you. Although it was an achievement that was a project run, we needed to sustain it. And the midwives were the ones who were very enthusiastic about sustaining that. And an example of the midwives realizing that it is not about staff shortage, it is about getting the community to be part of surrounding the families, surrounding the women, surrounding the teenagers, so that they're able to advocate for what the women need from the community as opposed from the midwives to the community.
Excellent, excellent. Thank you, Doreen. Great examples on how you have included the communities. Roa, what about you? How have you worked in Saudi Arabia to do women engagement, community engagement? How have you slowly built up the trust?
I think it comes also from the women, that they were looking for a birth, a physiological birth, without an intervention. And whenever they go to the obstetrician, they will say, no, this is the only way. Cesarean section are increasing because of the fear that they will have traumatic childbirth, fundal pressure still going on, episiotomy, routine episiotomy is going on, even for fourth baby. And women got afraid now to go through normal childbirth. So they are seeking a physiological normal birth, and they see women in other countries having this natural, without pain, without epidural, and they are accepting this natural process of giving birth. So they are coming to us as midwives through social media, through connected friends, asking where we can get this midwifery-led care. And it's really difficult to get a midwife who can start with you during pregnancy and then continue until birth with you. So, sometimes they question this care. Is this midwife is able to go into act when there is high risk happening? So always having a trusted relationship with an obstetrician. Whenever I have high-risk pregnant woman, I will refer her to the obstetrician, and sometimes the same woman will come back to me to have birth with me after she experienced the difference between obstetric-led care and midwifery-led care. Thank you.
Thank you, Roha. That is really interesting how you explained also the referral. So you refer to the OBGYN, but then there is also the contra referral, that the OBGYN refer the woman back to you. I think it's absolutely beautiful. And that you are explaining how women, they have lost their belief in their bodies, and they are starting now to look for midwifery models of care, so they can be guided through the pregnancy and childbirth by a trusted midwife. Excellent, thank you for sharing. So building on this now that we have discussed, could you give us and the audience some pieces of advice, lessons learned, or similar that we could take with us? As we have heard from ICM, we are all midwife leaders. We want to learn from you and improve the health systems in our contexts. And we are curious to learn from you some key lessons learned, how to move forward with midwifery models of care. Emma, I give first to you.
I think it is really important that, just like Janhavi was saying before, is that so often when we are thinking about these midwifery-led models of care, especially when they're outside of the hospital, birth centers, or home birth, they are only geared towards women that are low risk. And I think this is what I want to look at as my next step. And what we have done at the birth center, because we noticed that this was also the perception of women, and that they would say, okay, I can't go to the birth center because I have this and this risk factor. And it almost created a little bit of a divide among women, that there was a group that could receive this care and not. And so at the birth center, even though, yes, we can only provide birth services to this group of women that are low risk, we have tried to offer a variety of services that are open to everyone, so that everyone has an opportunity to receive care. And these are supportive care, such as physical therapy or lactation support, that is open to everyone. And we also have community events. We have parent groups or classes, and we are very careful about making sure that everyone feels welcome. And I think this is something that we really need to think about, also in terms of vulnerable groups or minority groups, that we make sure that everything that we are providing within the center is not only geared towards what we are considering as low risk in terms of the birth.
Thank you, Emma. Doreen, what would you like to share? What lessons learned would you like to share with all the midwifery leaders here in the audience?
Thank you. In South Africa, there is a philosophy, Ubuntu philosophy, which I'm sure one of our midwives, Professor Mulauti, in the crowd has been working with. And it is about people. One of the lessons that I have learned in South Africa is that if you want to serve a woman, she is part of a family, she's part of a community, and unless we take those services to them in the community, they will not come to us. So for us to win, it has to be shared humanity. It has to be us going to the community and engaging with the community and with the women and the families, and seeing the continuum of care rather than a linear approach, but a circular approach. They are capable individuals that we are dealing with, so we can own onto their power and their willpower to be able to engage with them. Thank you very much.
Thank you so much, Doreen. Roa, what about you? What would you like to share?
My advice is to start small, but think big. When I established the private clinic or the midwifery clinic, I wasn't trying to change the whole system. I was trying to solve the problem for the woman and her family by demonstrating the value of continuity of care, building partnership, and gaining the trust of the woman. We created momentum for wider change. Today, we are seeing more midwifery clinics opening across the country because one successful change leads to another, and then we grow after that. Thank you.
Beautiful. Thank you. Thank you to you for sharing all these lessons learned. And I think what I have taken with me from these panelists, that it's a process. It's a continuous learning curve. You adapt and you change and you get stronger over time. And that you, like many of them said, that you start small, but you think big. And this is really encouraging, that we are now longer asking whether midwifery models can work. We are now starting really to look forward. We are starting to see that it's doable, it's feasible, and we can overcome the challenges that we all have in front of us to accelerate and implement midwifery models of care at scale, to really achieve quality of care and equity, and also accountability and resilience health systems. So I hope today's sessions will leave us all with both inspiration and a practical sense that this is possible. It is evidence-based, it's about leadership, and it's community engagement. And when we all come together, magic will happen. So I will thank you all for joining us here today. And thank you so much to the panelists. Thank you, thank you.